My name is Cesar Alvarez, and I am a Legislative Fellow with the National Congress of American Indians, and I'll also be your webinar administrator today. I'd like to thank you for attending this presentation on Native American issues of health, translating pathways of health research, sovereignty, and philosophy into a community context, which is a part of our NCAI Diabetes Translation webinar series. Before we begin, I'd like to go over some of our webinar features. First, you should see on your screen the PowerPoint for today's presentation. If during the presentation you experience any lag in slide transition, it may be a result of internet connections and may need a moment to update on your screen. Currently, with the exception of panelists, all audience phone lines are muted until the conclusion of the presentation. If you would like to ask a question, however, you can type it in the questions box on the webinar control panel. After the presentation, we will also have a Q&A session, and panelists will answer questions submitted through the questions box. If during this time you would like to ask your question over the phone, please use the raise hand option on your control panel so we can unmute your phone line after the presentation. Also, our webinar software archives all questions submitted to the questions box. So if panelists are unable to answer or address your question, we will follow up with you after the webinar has concluded. Now that we've covered some of the webinar features, I'd like to turn it over to Dr. Malia Villegas, Director of the NCAI's Policy Research Center.
Thank you, Cesar. Good afternoon, good morning to some of our folks calling in from further west. Thank you so much for joining us on this holiday week. We are very excited to have this presentation commence today. I just wanted to give you a little bit of overview about the NCAI webinar series. It is Diabetes Awareness Month, and so we wanted to feature some of the great work that's being done as part of our project with Washington University in St. Louis. We are one of 7 centers for diabetes translation research, or CDTRs, that are funded across the country by NIH through its NIDDK Center. 3 of the 7 Centers for Diabetes Translation Research have a particular responsibility and emphasis on American Indian Alaska Native contexts, and we are one of those 3. The goal of our center is to prevent obesity and reduce health disparities, specifically with a focus on our Native populations, Native communities. A key part of preventing obesity and reducing the health disparities is to explore unique aspects of translation research in Indian country. And there are 4 particular areas that we've been focusing on here at NCAI in order to advance translation research. That includes policy advocacy, taking the best research that's out there and figuring out how to translate it into policy context. We also are focusing around co-occurring conditions. A lot of what we heard from tribal leaders as well as scholars in this arena is that our relatives who experience diabetes also experience challenges with cancer, with heart disease, and or with oral care, for instance. Diabetes doesn't occur in a vacuum. It co-occurs with other kinds of conditions. So we're trying to develop some research that addresses those instances. In addition to policy advocacy and co-occurring conditions, we're also trying to look at different kinds of outcomes in the research. Peer review publications are really important for getting information out there about what works, but we're looking at other kinds of outcomes like adaptation and replication. How are communities and clinicians working to adapt interventions that have been tested in other communities for use in our populations? And the 4th is around research guidelines and research regulation for tribal and other Native contexts. How does the context of research regulation really impact the kinds of research that can be developed, translated, and disseminated in different ways? So today we're really excited to have our 3rd of 3 seminars with Dr. Rodney Haring, who has a PhD as well as a Master's of Social Work, and I'll give you just some highlights from his bio and have him feature anything else that he would like to hear in just a moment. He is a research faculty member at the Native American Research and Training Center, NARTC, at the University of Arizona. He's an NCAI scholar, a past fellow of the Spirit of Eagles program with the Mayo Clinic, and a former Robert Wood Johnson Foundation New Connections grantee. He is also an adjunct assistant professor at Roswell Park Cancer Institute and the founder of One Feather Consulting, which is a joint venture company with Chestnut Global Partners. Dr. Haring, who is of the Beaver Clan, is an enrolled member of the Seneca Nation of Indians and resides on the Cattaraugus Indian Reservation with his family. He is a descendant of Chief Corn Planter and Governor Blacksnake with family origins from the Allegheny Indian Reservation. He holds a doctoral degree in social work. He's the outgoing chair of the Native Research Network. He's an has evaluation and research experience from the University of Arizona, Mayo Clinic, Harvard Medical School, SUNY Buffalo, SUNY Stonebrook, and in the private sector. He's a past research advisor to the American Indian Alaska Native Health Research Advisory Council, or HRAC as it's known. And in 2010, he was an expert panel member to the United States Department of Education, the White House Office of National Drug Control Policy, Executive Office to the President. His research interests intersect various health disparities, which are prevalent within Native American societies, with a special interest in cancer and obesity. Other research concentrations include health policy, research ethics, and workplace interventions. He is a good friend and colleague, and we are very excited to feature some of his work today. Dr. Rodney, turning it over to you.
Well, thank you for the introduction. It's truly my honor to provide information, not only in the academic context in the research world, but also back to our communities, and kind of talk about a little bit about how some of the research is being conducted out there, including my own, but other things, including research ethics, are translating or can translate or have applicability to our tribal communities in North America, not only here in the United States, but also in Canada as well. So I'm honored to be part of NCAI as a fellow. I'm very thankful for all the opportunities and all the great work that they're doing there, and also the opportunity to work with the University of Arizona, the Native American Research and Training Center. I currently reside on the Cattaraugus territory of the Seneca Nation of Indians, but through a unique collaboration, I also work at the University of Arizona, and among other places like NCAI and in the past, the Mayo Clinic. So before we start, and I'm going to include something that comes from our people here in the East. We're known as the Haudenosaunee, or as the French called us, the Iroquois or the Iroquois, but we're the people of the Longhouse. And before we start any kind of event, including something of this nature, a conference, a webinar, a gathering of people, to promote wellness and a good mind, we often start with what's called the Ganonyok, or the Thanksgiving address. And when we think of Thanksgiving, it's not like we're going to go eat turkey right now, or on Thursday here we're going to have turkey. It's a little different. It's about giving thanks for the things in our world and how they interact with us as people, with our wellness, and you'll see how that kind of, I'll talk about it a little later, about how that kind of can translate our findings in a Western context into some philosophies of indigenous and native peoples. The Ganonyok has its ancient roots dating back over 1,000 years to the formation of the Great Law of Peace by a man called the Peacemaker, and perhaps even before that time. And again, today these words are still spoken at the opening and closing of a lot of ceremonies and gatherings held among the Haudenosaunee. And a lot of indigenous cultures have the same premise of sharing. So I'd like to share that with you, and if you could advance to the next slide. Again, it's called the Ganonyok, and I'll recite a small version, a short version of that. Taona di nakechon wio ongoyante iyo. Nihuna ganok sha. It would now yo, quego scano, esweno danyo, daniho nyo tenegwat nagoy. Taone, it would now yo, which nocton ka wene, yo enchite, daniho nyo tenegwat nagoy. Taone, it would now yo, which nocton ka wene, hadikyot gate, daniho nyo tenegwat nagoy. Taone, it would now yo, which nocton ka wene, hadikyot gate, daniho nyo tenegwat nagoy. Taone, it would now yo, which nocton ka wene, say so ujistan that said, daniho nyo tenegwat nagoy. Taone, it would now yo, which nocton ka wene, what hot daniho nyo tenegwat nagoy. Taone, it would now yo, which nocton ka wene, Joheko, daniho nyo tenegwat nagoy. Taone, it would now yo, which nocton ka wene, a nook what said, daniho nyo tenegwat nagoy. Taone, it would now yo, which nocton ka wene, o nega nos, daniho nyo tenegwat nagoy. Taone, it would now yo, which nocton ka wene, Genzo, daniho nyo tenegwat nagoy. Taone, it would now yo, which nocton ka wene, Tia wenya dani ho nyo tne kwat na goi. Taone Edward na nyo ho chnok tang ho ka we ne. Soi ka ka kwa dani ho nyo tne kwat na goi. Taone Edward na nyo ho chnok tang ho ka we ne. And ka kwa dani ho nyo tne kwat goi. Taone Edward na nyo ho chnok tang ho ka we ne. O ji son da dani ho nyo tne kwat na goi. Taone Edward na nyo ho chnok tang ho ka we ne. Jite o so on dani ho nyo tne kwat goi. Taone Edward na nyo ho chnok tang ho ka we ne. Hada wena da just dani ho nyo tne kwat na goi. Taone Edward na nyo ho chnok tang ho ka we ne. Ke hatia ke no dani ho nyo tne kwat na goi. Taone Edward na nyo ho chnok tang ho ka we ne. Kanya dayo dani ho nyo tne kwat na goi. Taone Edward na nyo ha ho chnok tang ho he ju he to ge so ka we ne we go te kwat we ne dani ho nyo tne kwat na goi. Dani ho. And so that's a brief version of what the Haudenosaunee would refer to as the Ganonyok. And each speaker and person that shares that often says it in a different way, but basically it starts giving thanks for things in our environment and starting off with the people. We're thankful that we're here, and after every sharing of things, we present that we're thankful for our health and well-being, that our minds are all together in one in this meeting and outside to the workplace, at home, and in the environment, that we're giving thanks for various things that are out there, and that we're all combined as one mind, thinking of good things and wellness. And it goes on to share things about the earth that we walk on, and the things, having the ability to plant in there, and having the ability to, be part of the earth. So we all give thanks, and we put our all minds together and give thanks for these things. It goes on to give thanks for items like the water that we have, so that we can drink that. And these things I'll talk about how they're applicable and to both scientific results, but also community-based information. It goes on to talk about medicinal plants that are in our indigenous areas where we live. Some of the things like Johiko, or the three sisters that are part of the food and staple of life here in Iroquois or Haudenosaunee communities, the corn, beans, and squash. All these things in our environment are important. And then we go on to give things, we slowly make our way up into the winds that clean the air, the water, again, the intersection between water and wind, and also the birds that provide us songs, and the various things, including food, the animals that are out there to provide us food. And then even further on to the stars that guide us on at night, the sun that keeps us warm, the moon that has its own unique abilities in the world, and to our Creator, and the things that are important to us. So we all give thanks in this respect. And so I just wanted to share that with you, a little bit of our ancient language and our ancient philosophies, and the creation of how the Ganonyok is important to many things. And if you could advance to the next slide. You'll see that part of that, when we talk about the Ganonyok, and we can look at that as part of our health. How does that influence? We're part of that. And when people ask me, what type of research do you do? And as a researcher, we get that question quite often. What type of research do you do? And I often say, well, I do health disparities type research. And they ask, well, what does that mean? Well, to me, it's the intersection of many things that influence one's body. The environment influences health. Where we live influences our health. And to be an expert in one area, we must think about two or more in their influences. And we're talking about diabetes now. And Dr. Malia had mentioned, it doesn't happen and you just have diabetes. There's some things that co-occur with that. For instance, obesity can be a precursor to diabetes. And then eating and drinking bad can be a precursor to obesity, but it also can be a precursor. It can affect your oral health and your dental health because of the things that you eat affect your teeth. And then there's even relationships between obesity and cancer. And so there's a number of things that are occurring within oneself, and to look at that, we have to look at it not as just one thing, but as multiple things and address multiple things and be aware to assess for that. So that's the type of research that I try to promote, and that when we look at things, it's not necessarily looking just at diabetes or we're looking just at obesity or just at cancer. We're looking at a multitude of things in order to be effective, to be aware of what's going on within one's body and one's health. Next slide, please. And so some of these health disparities, these are taken from the Centers for Disease Control about some of the most prominent health disparities in Indian country. We have cancer at a higher rate than in non-native societies, obesity and diabetes, and again, all of these kind of intertwine to some respect. Heart disease, suicide rates, alcoholism and other substance abuse problems, auto accidents, and also the life expectancy for Native Americans is a lot shorter than the U.S. population. And so a lot of these things, when we talk about health research, we talk about co-occurring conditions, you know, there's more than one. There's more than one. If you look at the left side here, when you have cancer, obesity, and diabetes and heart disease, one can have all those things at the same time. So when we do an assessment or we do are developing research agendas to help out in Indian country, you know, we need to look at all these things and how they interplay with each other and to address them to be an effective health intervention research agenda. Next slide, please. And so again, some of these co-occurring conditions, and here's some examples. And we'll get a little more in depth about the research that's been conducted in the obesity and oral health arena. But also some of these things lead, as I mentioned in the previous slide, is obesity can lead to cancer and diabetes, or oral health disease and mental health. Those who have teeth that are concerned to the individual that has teeth that are not what they feel are not appropriate or need some more care, then they may have mental health issues about that, whatever it may be. So those two are interrelated as well. And also alcohol and auto accidents. You know, there's a lot of substance abuse in our, as noted in one of our health disparities, and that's highly related, alcohol and auto accidents. I'm going to go to the next slide, please. And so the impact on these comorbidities, and this is taken from the American College of Preventive Medicine, the rates of obesity-related comorbidities are increasing in adolescents. And so they're estimated that 3 of 5 obese young people already have at least one additional risk factor for heart disease, such as high cholesterol, high blood pressure. Over 25% have 2 or more. Overweight and obese children and teens are approximately 10 times more likely to develop hypertension in young adulthood, and more than twice as likely to develop diabetes. Type 2 diabetes used to be rare in children, but has become most common type of diabetes diagnosed in several pediatric diabetes centers, and it's growing. You know, it's a new diagnosis for youth under age 19. And, you know, in the conversation I had with Oren Lyons, also a member of the Haudenosaunee Nation's Onondaga, and he said years ago when we played lacrosse, lacrosse is indigenous to the Haudenosaunee, and a lot of people are familiar with the Iroquois Nationals team that plays across the seas. But look, he said many years ago when he played, and even before that time, just growing up, a lot of lacrosse players were slender, thin, and there's been a change. And you look at a lot of lacrosse players of today in our communities, and it's not that way. So even, you know, taking that concept and looking at that, there has been a change in time from what it used to be until today. Other complications observed, increased rates in obese individuals include pulmonary disease, which might be seen as asthma, sleep apnea. It can be gastrointestinal hepatic complications, and fatty liver disease. In addition, children who are obese are at greater risk for bone and joint problems, and also some psychological problems, much like the oral health concerns, to have poor self-esteem. Next slide. in a short while back, I was funded for a project called through the Robert Wood Johnson Foundation New Connections program. And the project was to look at some of the obesity and oral health interventions and their commonalities in the Native American landscape. And I put here Western science because these programs that were out there, basically what we did is we looked at all the literature that's out there for intervention work for obesity and oral health interventions in Indian country. And we were trying to look at some of the commonalities or best practice or best ingredients of what makes a successful intervention between these two co-occurring conditions. And so the childhood obesity, and we know that's a concern in the United States and in Canada and across the world, but in Indian country it's a little more of a concern. And the rates of obesity and its health-related consequences in Native peoples are higher than non-Native populations, and prevention and treatment options are both lacking and ineffective. And I'll talk a little bit more about that, but they're really there's a growing literature and intervention work for Indian country for obesity, but it's still kind of in its infancy. It's still being developed, and I think NCAI does a good job at making us aware of that and promoting more intervention work in Indian country. So we appreciate that. I appreciate it as a community member. And also, Native Hawaiian children discovered the prevalence of obesity among Native Hawaiian youth to be double that of the same age youth from a national survey. And on the opposite side here, you'll see a co-occurring health disparity of oral health. A lot of people are not cognizant of this issue in Indian country. Native American youth experience oral health problems at a disproportionate rate. 68% of Native children have untreated tooth decay. 33% report missing school because of dental pain. 25% indicate they do not laugh or smile because of the way their teeth look. And left untreated, a lot of things can cause significant negative impact on the quality of life, leading to problems in eating, speaking, and learning. And so other consequences of oral health problems, and I mentioned this earlier about, it can lead to heart and lung disease, stroke, pregnancy, complications, preeclampsia, and oral health cancers as well. Next slide. So what we did was we looked at, we did what's called a systematic review of all the information, and there were multiple people helping kind of scrub all the information that's out there from various databases on studies that looked at childhood obesity interventions, that looked at oral health interventions specifically for Native American First Nations youth to find out what was out there, what was working, and what were the common practices between the two or among the two. So out of that, which isn't entirely a lot of studies, but there were a total of 120 articles collected. And out of those 120 articles, 94 were just basically background prevalence studies, meaning they were showcasing how much of an issue or how much of a problem it was in Indian country. Out of those 120, only 26 were intervention-based studies. Next slide. And these are the results that came from those studies. And so what we did was we looked at it using a qualitative analysis paradigm called grounded theory. We compared and contrasted some of the information that were coming from those studies, and with a particular focus on, the process of intervention and the things that were happening that were kind of meaningful, that could be meaningful for Indian country. And out of that literature came, we have here consuming in healthy ways, drinking and eating for wellness. And so with grounded theory, I think in the qualitative sense, it fits well with Indian country because we're looking to do something that's action-oriented. You'll see I added ing up to each thing, meaning it's something that we as communities or we as health researchers need to work with communities to promote. And so it's an action item called a gerund when you add an ing. I try to do that with a lot of work that I do because we want to make sure that these things are just sitting out there in a paper, and that we want to make them action-oriented for our communities and translate some of these results into a community context for use at health centers, Native urban centers, and the community as a whole. First one here, again, consuming healthy eating and drinking. So a lot of the obesity literature talked about, healthy eating, how to eat properly, and this isn't a hidden fact, this isn't a hidden finding. But what was very interesting was the drinking for wellness. So the oral health piece talked a lot about drinking properly, and not drinking sugary drinks, and promoting the drinking of water, which kind of falls back into some of our, at least in the Haudenosaunee framework of, and some of our readings, and some of the things that can be found like in the Iroquois reprints. There's a book called Iroquois Foods and Food Preparation that noted in some of these historical documents of our people that water was the main thing that we drank. And it's part of our culture. And so when we think about that promotes healthy oral health, wellness. It also promotes obesity prevention. And so consuming in healthy ways is very important. That was one of our core categories that emerged, that we not only need to think about eating in a good way, but also drinking in a good way. The second one, also very important, was the shaping of the school environment for obesity oral health interventions. And that a majority of the interventions that were done, especially in the obesity literature, focused on doing interventions in the school setting, all the way from the Head Start setting into grade school and into high school. So it was an important place to consider implementing obesity intervention programs. And the same is true with the oral health. On the oral health side, you'll see that working in the Head Start in collaboration with, for instance, the Indian Health Service Center to do screenings, to provide fluoride treatments, varnish. And so it was important to understand, well, these are important at an important place, an important intervention environment to consider. So that was key. And of course, incorporating culturally tailored activities. Jumping back to the obesity literature, it talks about promoting activities, and for our area here, the Haudenosaunee had mentioned lacrosse is important. So how can we incorporate lacrosse and obesity interventions and making it appropriate for our community? Is it through the school system? Is it working with organizations in the community? But how do we really incorporate culturally tailored activities? For others, it was going horseback riding in other studies, and berry picking was another one that came out. And again, that's part of, you see the next one here, promoting physical activity. So culture activities incorporated into physical activity was important. And then involving family. And you'll see that with a number of studies. And probably, I think, a majority of the studies, both in the oral health literature and obesity intervention literature, promoted, involving family members. Involving family members on teaching their children how to cook properly, proper proportion size, promoting water at the table, things of that nature. And so it wasn't just the children, it was the entire family that had to be incorporated to make change. Attending school functions and obesity intervention programming with the family, not just the student, after school programs. And ultimately intervening over time. So multi-year studies were, multi-year interventions were most important within both contexts, the oral health and obesity. So it was usually about 3 to 5 years that an intervention took place. It wasn't something that happened, over a few weeks. It was a multi-year intervention that happened in a school setting that was very key in improvement across the studies. And in a lot of studies, with the exception of maybe 1 or 2, they didn't talk about oral health. If it was an obesity study, rarely, only a couple of studies talked about oral health. And the same is true about the oral health studies. Very few talked about obesity interventions and the co-occurring health disparities. But the results were very similar. The intervention progress, the interventions put forward were very similar in nature. Next slide, please. And so we think about, the Western science, and when I say Western science, this is something that maybe comes from an academic research setting, And we think about that, about these studies that were conducted with our communities and what that may mean. But what does translation and research mean to Native communities? So we have something that came out of this research, and I just presented, from an academic, from a research standpoint, from a college standpoint. This is what it means in this setting. But what does that mean to a Native community? And in the next part here, you see interventions, and so maybe some of these things are maybe considered evidence-based practice. And so there's a beginning touch of how it's applicable in Native communities, how it's evidence-based for Native communities. But what else is out there? Are there other interventions that come into our communities that may not be applicable or have been tested for our communities, but they're still considered evidence-based practice? So it's a very good question to ask. And the flip of that is PVE, or practice-based evidence. So things that are occurring in our tribal communities that are effective, we really need to pay attention to that. So under our obesity oral health interventions or policies that are important and meaningful to our communities, this is important to highlight and show, hey, this is practice in our communities. It's a practice-based evidence that appears to be working well in our communities, and how does this interact in a reverse way to Western science? So those are important considerations to think about when working with interventions in general. And will tribal communities find interventions relevant? How might a community translate for their use? And so these are things that, I presented some information on some of the findings that are coming out of obesity and oral health and co-occurring conditions, and how they interplay with the person and how in the community and various health disparities that are out there. But perhaps if we move to the next slide, we can translate that and using some philosophical underpinnings of the Haudenosaunee or whatever tribal context you're from or are familiar with. But in our frame of thinking, it may be the case that we use something called the good mind, or the Haudenosaunee philosophy. And what that is that when we work for peaceful health, we develop a good mind, which translates to a good way of thinking. And when we work for peaceful health and a good mind, we develop strength. And in the context of what was presented, we can eat better, we can exercise more, and we can take back our health with good intentions and well-being. Next slide. And so part of that is strength. It's our choice how we use our courage, and as part of that we can find the good that comes from thinking and acting and responding in good ways. And so these are things that would be important to when you look at health interventions or research or things that are applicable in Indian country. It's a good way to look at that, how we pull the strength and courage from the things that we look at. Through courage of good thoughts, when we have the power to love and courage and the ability to use our knowledge of health, wellness, and motivation. So, and you'll see a lot of this in our resiliency work that's coming about that's important to our communities. How do we look for the positive in things, and how do we move that forward in a good way? Next slide. And so I flip back to the beginning when we started. We talked about the Ganonyok and the giving of thanks and the relationship for obesity or health interventions and the betterment for our societies. So if we think about that, about using the relationships for the Ganonyok, we have here like the first one I put in Seneca, the planting of Johiko, or our three sisters, the corn, bean, and squash. And so when a family goes out, it's an activity that a whole family goes out and plants and nurtures those plants to grow and takes care of them. So you're showing and nurturing how to care for plants or watching them grow with your family context. And then you go to the harvest, where you go out to harvest the plants, and it's exercise going to harvest. And then you pick the plant, and then ultimately you make a dish from it, a healthy dish that comes from the earth. And so what better way to translate that, some of the findings of working with family, promoting working with our earth, and to provide health by eating something healthy. So that's one example. And the next one down, picking Ojistandatsan, which is our wild strawberries, which are a medicine for the Haudenosaunee. And they taste pretty good too. And so it's important to to go out there and to recognize some of our historical and Aboriginal plants to our area and to our culture, and to be familiar and thankful for them, and to use them in a good way. Same is true for hunting. to go out and to hunt. It's a physical activity, and it's working and teaching and learning about your environment, and then also getting the food, preparing it, cleaning it, dressing it, and then putting it on the table to eat in a healthy way. The same thing is true for genzo, which is fish, all the things that are provided by the fish, so it's important to incorporate all these things. And so the eating of healthy meals prepared from above is very important. And the drinking of a niganos, or water, is our life. We need water for life. So if you look at that in the context of a Haudenosaunee person, you know, it's important that the Ganonyok provides us all these things. And I learned from an elder in our community, Clayton Logan, who shared this information and kind of discussed how this is important to us. And if we look at that, a lot of the answers are right in the Ganonyok and how we think about and interact with it. So it's important to tie all these things together, whether it be through Western research or Western science, and how that interplays with some of our indigenous and community context for the importance of health. And we move to the next slide. And we move into sovereignty, and we're going to define that a little bit, and how that can also interplay into the health of our people and the relationships with some of our health research, our community, indigenous philosophies to that, but also tying into our sovereignty as Native nation. So often it's considered a nation-to-nation governmental relationship where tribes have been in relationships with the federal government, for instance, since the beginning of when European contact occurred, and often through treaty rights and things of that nature. So it's a relationship that's happened over time. And so nations have the ability to create sovereign mindsets on how to shape and move their health policies forward, how to create health interventions, co-occurring health disparities, and addressing that from a sovereign standpoint. And also, and Dr. Malia had mentioned, you know, our research ethics. You know, we have the sovereign ability to shape the research that comes into Indian country, how it's conducted, how it's collected, who has rights to the intellectual property, who should be involved in the process, who's included in as a tribal employment rights office included in the hiring of people that are helping with the project, things of that nature. So it's very important to understand that you know, health research is good, but we also need to attend to the sovereignty of how it's conducted within our landscapes. And also policy, sovereignty and policy. We have the ability to, as sovereign nations and as Native nations, to shape the policies that are relevant for our own communities, not being dictated by a county or a state or even a federal government. We ourselves, as Native nations, have that ability to do that. And move to the next slide. We also have the ability to shape, you know, see here, health sovereignty, as I coin it. It's an obtainable goal in Indian country. Oftentimes, federal policy standards should not always shape or dictate tribal health, as they may not be applicable in some respect, but they can help inform and serve as collaborative guidelines. Tribes have the sovereign ability to integrate traditional healing, for instance, into healthcare, which may be separate from federal policies or federal guidelines. These are important to incorporate and consider when addressing co-occurring disorders or concerns in Indian country. And tribes have the unique and sovereign ability to develop policies related to developing safeguards for societal health. And that, again, would be maybe some of the research being conducted in Indian country, but also the policies that our health centers have that can shape how we do interventions in Indian country. Or at a tribal council level, how can council develop, for instance, an obesity policy to work with healthcare centers, or an oral health policy to implement through the dental health clinics through IHS. We have that sovereign right to do that, and if we evaluate and research what's working, what isn't, and maybe take some of these guidelines that are out there and look at them and see how they're applicable, I think we can do a really good job and using what I would say health sovereignty to reach our people in the communities without having how can we be a sovereign nation if we can't feed our own people, if we can't provide health care for our own people in a meaningful and helpful way? So in order to be a true sovereign, we need to think about that and how we can move forward to make our people healthy. Next slide. And so at a recent presentation and conversations with Dr. Donald Warren, who's a Guala Sioux and is Director of National Public Health Program at North Dakota State University, he talked about the Affordable Care Act and how that can promote sovereignty by some of the things that are included, like the permanent reauthorization of the Indian Health Care Improvement Act is included in the ACA, so that's important. That's an important feature for Indian country. It helps strengthen the Indian Health Service by including that. It provides greater access to health insurance coverage for Native peoples and societies, and it provides additional options for health insurance. And by doing so, people have the opportunity to look at healthcare options and not necessarily having to go to IHS, but if they happen to go to IHS, they can also use the ACA there to help defray the contract cost for contract health within these centers. And offering more options for healthcare is an extension of the U.S. government's trust responsibility to Native nations. Next slide. And some of the things that promote the sovereignty and work in collaborative efforts that tribes can consider would be tribes can purchase on behalf of tribal members through ACA. They can work directly with the plans, and tribes can also decide which plan they wish to sponsor, if they wish to sponsor. And I think it's a unique opportunity to promote health sovereignty and provide greater options for tribal members. Next slide. And so why would tribes and members choose to participate? And again, it saves Indian Health Service contract health service dollars. So by signing up and learning more about it, it frees up more funds potentially for Indian Health Care Center. It offers tribal members the option of going to IHS Center or going to a private practitioner. Tribes can also pay for cost sharing of tribal members, and tribes can also pay for co-pays. There's a lot of latitude in which tribes can work with the ACA to promote sovereignty of health in their communities through this new mechanism. Next slide. And so to summarize that, sovereignty to shape the future, and I want to give a thank you to Mr. Carson Waterman, who is an artist at the Allegheny Indian Reservation, Seneca Nation, who helped develop some of these images for the manuscripts that are under review for the Robert Wood Johnson Foundation New Connections Project. And I have a couple manuscripts that relate specifically to this presentation and in the field of obesity and oral health interventions in Native American communities. But sovereignty to shape the future. The health of peoples is the health of individuals, the health of family, and the health of community. In order to have the health of a community, we need to have healthy families. And to have healthy families, we need to have healthy individuals. So even when you think about co-occurring conditions, we think about co-occurring wellness as well. So if you don't have a healthy individual within a family, that's going to offset the family being healthy. So we need to look at these different layers as well when we address a concern. And so it takes a macro level approach to look at individual, and you can look at this like, well, there's counseling for individuals, there's family counseling, and health of the community could be shaped by policy. But all these things need to be in line in order to address it. And you'll see here on the picture here by Carson that we have a tribal council making policy changes and electing, and you see on the right side, to make policy changes in regards to healthy eating. Next slide. And so shaping the future of translation. So again, I'm very thankful to have had an opportunity to share some of the work out there that's going on, and to be part of NCAI and the wonderful work that they're doing. But to incorporate that, we need to all challenge ourselves to continue learning and developing culturally relevant interventions for our communities. We can't sit sit by and just wait for an intervention to come in to do good work. We need to be part of that process. And again, going back to an action-oriented intervention style of, really taking a look what's working in your community or not working in your community is important. As a research scientist, to go out there and really do a good job at looking at interventions in a good way and a good mindset on developing research projects that has the ability to not only be meaningful to the world of science, but also meaningful to our tribal peoples at all levels, from an individual to a family and at the community context. And by doing so, it prepares our practice and intervention styles and moving forward of health and wellness, like we talk about in the Ganonyok, in Indian country, for our 7th generation. And so in the Haudenosaunee context, we look back in the 7th generation philosophy, and we're always looking forward on how what we do influences 7 generations forward. And so it isn't just me looking to be well, it isn't me just looking to provide wellness for my children and family, but looking ahead for their children's families, and setting the framework and the foundation of how we do that, and to be successful at least providing a foundation here, a very important issue of obesity and oral health, because that's affecting our people so much. And we really need to pay attention to that and see what we can do. The community are very knowledgeable, and so it's often important to reverse translation of how the community can guide researchers, for instance, what's out there that can be beneficial, and to open the line of communication between the two to be important. I think it was Tom Porter of Haudenosaunee. He talked about this philosophy in the 7th generation about, don't be the generation that didn't do what they needed to do to make, in this case, health a success for our future. Don't be the generation that didn't examine or look at it in that way. Be the generation that provides a foundation, a footstep, a blueprint of how we can continue to be healthy people. And again, Carson Waterman's depiction of some of our culturally relevant indigenous medicine games of lacrosse here, and a young man smiling with healthy teeth. Next slide. I believe that's the last slide. And on this PowerPoint presentation, I'm providing my information. Very happy to talk to anybody about these issues and concerns and some of the research that's been completed. And I turn it back over to Dr. Malia. Again, Yahweh, which means thank you, and I appreciate the time.
Thank you so much, Dr. Rodney. I just want to give a few reflections and kind of takeaways here. I'm always really encouraged that the many, many hats you wear there in your community and in the academy really come through in your presentations. As someone, who's really committed to children and families, I think that comes through. I don't know how much you said about your passion and responsibilities in the lacrosse arena, but I always love hearing some of those aspects, as well as some of your work with employers that came through in the ACA aspects of the presentation, and of course your research work. So just, the many different hats that often Native scholars are called on to carry. But you started us off in a really good way, and I really want to thank you for that, because the notion of ceremony really came through for me in your presentation, and I was really struck by how much a lot of what you said reminded me of the words of one of my mentors and elders, Ganonyok Oscar Coagley. And one of the phrases that I always carry with me of his, you really invoked, which is that the mindscape forms the landscape, and that the landscape forms the mindscape, which is about relationship, but that, the things that we have in our mind, and if it's in a good way, will inform our action and what we create in that landscape. But the landscape, the access to healthy foods, the policies that are there really inform how we can develop our sense of ourselves in community as well. And so I just want to appreciate that and thank you for that reminder and that grounding in this work. I think I was really taken by the notion that in your literature review, in your synthesis, your meta-analysis here of the different studies, that you found that the oral care research isn't really speaking to the diabetes research, even though there were very similar findings in terms of what it takes to get to effective interventions in that way. And so again, I think this is where, you know, scholars in this space, and you are adding value to this arena by saying we need to connect the dots here. We need to look at the relationships, you know, and again emphasizing why a focus on co-occurring conditions and diabetes translation for our communities and our people is really important. I really love the fact that family-centered interventions and practices really came through here. I think that echoes a lot of what we've been learning from the Special Diabetes Program for Indians in their application of the diabetes prevention program in our context, that it's, you know, one-to-one counseling can be important in a nutrition and exercise context, but the more that you bring the generations together and build some family-centered notions. And what I was really hearing through that was, you know, educating ourselves and re-educating about what to eat and how to engage culture in a physical, kind of active way, really thinking about needing to learn that and taking our time. You know, I think often in the pace of broader society and in many tribal communities where everybody's wearing different hats, eating and exercise, you know, are the last things on the list. You do it on the fly. I did it today, you know, running from meeting to meeting, you know, but stopping and really honoring that space is something that I heard come through in your discussion, and how the family can be a big part of that piece. And I loved your description of health disparities, how you story this work when people ask you about your work. Because I know that what's come up for us a lot in the tribal context with our tribal leaders is that environmental health is a critical component of human health. And the way that you talked about health disparities as the many things that impact the body, I think really allows for that broader understanding that humans aren't just at the center of how we think about health in Native contexts, and perhaps the way we should think about it in other contexts as well, that there is real important symbiosis. And I think lastly, the thing I'm taking away from this is the great description and concept of health sovereignty. We talk a little bit about here at NCAI, definitely sovereignty, but the idea that, again, it can be a lever that tribes can use to actually address co-occurring conditions was something that hadn't occurred to me beforehand. So I appreciate that insight on this front. But thank you for the very rich presentation. And I'm going to turn it over to Caesar to see if we have any questions that have come up as a result of the presentation. And he'll tell you a little bit more about how you can, again, raise your hand and do that kind of thing if you want to speak.
Sure. We have just one general question, and you are welcome to enter your questions in the questions box you will see. And I'll read those out, and if you would like to just personally ask, you certainly can at this point. I know there are a few who may have been raising their hands earlier. You may not have entered your audio PIN, and so those are unique to each participant. And so if you can do that, we can certainly unmute you, but if not, we can certainly, I'll read out the question if you could send it in. Just a general question we have is if the slides are available to participants.
Yes, Dr. Rodney has offered to share those, and we'll send that out to the list after the webinar. Thank you for that question. Deborah, just got a hand up.
At this point, there are no other questions at the moment.
Dr. Rodney, can you share a little bit with us about where this work goes in the future, where your next steps with some of this are leaning?
So I think that the information that's out there provides some future direction for research and translation of some of these interventions to communities. In particular, I think the one piece that came out of the systematic review was that there was a multitude of study that was conducted with a program called the Pathways Intervention. And so I think there's an opportunity to kind of look at that and ask communities, you know, it was done with over 1,500 students, and I think over 20 different school districts, 20 different tribal nations in the Southwest. And, you know, we could look at that and say, what worked, what didn't work, what could be changed, and maybe fragment pieces out of that. I know that intervention is still available, but why hasn't it carried forward to tribes in the Northeast, for instance, or to bands in Canada? I think that would be an important question. So, and then some of the other things that, and you had touched on it. There really isn't much work in the oral health intervention arena. So to encourage researchers, native and non-native, to look at that, how it's very important in Indian country. We have a higher rate of oral health disease than most people in the world. And so what type of interventions are important or relevant for native communities, both youth and adults? And other things that came out of it, look at other co-occurring conditions. And so a research project I'm currently developing looks at the relationship between obesity interventions and cancer interventions, the relationship with obesity and cancer education for workplace populations, how to develop something that's relevant for high-risk workplace populations such as native workforces or others that are affected by cancer, obesity, or diabetes. And so I think the work is important. There really isn't too much out there that looks at both of those things that co-occurring. And even though the interventions are very similar in some respect, have common core ingredients or best practices, there needs to be policy that's developed that looks at both of those things at the same time, among other things. So I think that's very important.
I know we have a few students, kind of budding researchers on the line. Any advice that you would have to them, just given some of the priorities you've laid out today and just, the need for more work in this arena? Any kind of advice for budding researchers?
I think to come up with innovative, creative ideas to help our people. A lot of tribes get stuck in, business as usual or intervention as usual. To work with tribes and to listen some of that practice-based intervention that comes out of the communities, and to really, go out there and see what's going on. To develop research agendas that are respectful to the communities, and as a junior scientist, don't give up. Everybody's made it this far as a junior investigator, or we have our PhDs, we're doing health research, and we have that ticket to do. We have that charge. We have that, and we're talking about the 7th generation. We have that that knowledge and piece of paper hanging on the wall that says, hey, you've been selected to do this type of work. So go ahead and do it. Put your left foot in front of the right and move forward in good ways and do what you need to do to help our people and keep our health going in a good direction and to promote health sovereignty.
No, at this point there's still no other questions being asked.
I've got one more for you. I just taking advantage of the opportunity. You sit physically in a very, in Cattaraugus, but your purview is very expansive and also place-based there. What do you want? What would you say to tribal leaders? Based on your work and your experience, what do you want them to be thinking about? You talked a lot about being, action-oriented, and we know that leadership is so critical in different ways. What are some of the things that you talk about with tribal leadership, who are struggling with some of these issues of health disparities?
Well, I think, and having gone to council a few times to talk about some of the research and some of the intervention work I've done in Indian country, we're always last on the agenda. It's like, I think that it would be important to sometimes place our things at the top of the agenda and to have a greater discussion about that. So I think that's important to, there's a lot of things that are very important in Indian country, economics, for instance, or things that are happening at the tribal level. But health is also important. And to be first on the agenda to discuss those issues, I think, is key, and to create new policies. And so there's a lot of opportunity for tribal leaders to develop committees to look at policy, to promote health policy and the creation of health policy above and beyond what's out there for county or state or federal, to develop their own, to create means to promote the health in our communities. And a tribal leader, it's a responsibility to do that, and to look at that, and to always be aware of what's out there. Here at the Ganonyok, I think there's a new movement called Food is Our Medicine, and it's a great movement to look at some of our Aboriginal plant life and how to incorporate that into healthy eating. And so I think other communities can learn from that experience about how programs such as Food is Our Medicine, or implementing food-related policies in our early childhood learning centers or a Head Start, to evaluate what's being eaten. Here at our center on the Cattaraugus territory, I see that there's food focus groups to kind of provide information back to the dietitians and the folks making the food in the kitchen to inform about what should be on the menu. It's important. So all those things related, and certainly as a tribal leader, it's important to look at policy and evaluate, to evaluate the health programs, to do program evaluations of your departments, to make sure it's included, to make sure that these healthcare programs are doing what they're set out to do. I think that's really key for tribal communities and leaders.
We do have one question coming in. What is the future of translational research for those American Indian Alaska Native populations in urban centers where we still see disparities but possibly not the same tribal infrastructure?
One more time for me.
What is the future of translational research for those American Indian Alaska Native populations in urban centers where we still see disparities but possibly not the same tribal infrastructure?
I'll pass that one back to Malia. I think there was a webinar specifically on that last week.
Indeed. We had a great webinar last week on this topic, and I know that we talked about a couple of different things. One of the big challenges is really identifying Native people in an urban context, finding place and space, and being able to really enact sovereignty. We here at the Policy Research Center assert that tribes have sovereignty over research that happens on their lands and with their citizens, and that includes citizens in an urban context. So I think, what our partners at the National Council on Urban Indian Health, NCAI, Dr. Jamie Bartjes and her research partner Nicole Yuan at the University of Arizona, they were really highlighting the real need for more research. One of their outputs was that they did a literature review and of over 300 articles related to American Indian Alaska Native diabetes, 8 over a 10-year period were focused on the urban population. So that's less than 1 per year. So there's a real need to not only begin to identify communities of urban Indian people, but to demonstrate the benefit that translation science, I think, can have, and to foster more of that. They talked also a lot about violence experienced by urban populations, and particularly youth in urban places. There's a lot of transience and mobility that can contribute to that, and some economic, low-income economic challenges that way. So I think in terms of translating research, it's really about beginning to, what I took from that presentation was beginning to understand the urban Indian population better, and in different ways, recognizing that as with any population, it's not monolithic, it doesn't look the same in different contexts, but understanding too that there is a lot of interplay between the urban and rural, people moving back and forth, so it's not also a fixed kind of space. So I think that was the big takeaway, is in order to improve translation research with urban Indians, we have to understand their population better and understand how people move between our communities in different ways. But we will be hoping to get that PowerPoint out. They've asked us to hold it back right now because they are submitting the manuscript that it's based off of for publication. But they did send out a link to the 8 articles that were published, and I'll be happy to attach that to what goes out along with this webinar as well. Thanks for the question.
At this point, there are no other questions.
Dr. Rodney, did you have any kind of concluding comments, or are you all set?
Another thank you for the opportunity to share some of our work. And when I say our work, as the NCAI and myself and the other colleagues that we have are doing this type of work in Indian country, and the ability to work cross lines here. You know, it's a webinar is a unique technology to have people listen and to reach, you know, anywhere in the world. So it's important that we continue this on, and very thankful to be part of NCAI. And thank you, Dr. Malia and Caesar, for your help today.
Thank you so much. We really appreciate the time and the presentation and the insight. And thank you all for joining us today. This is the third of three, but we do encourage you to visit our Center for Diabetes Translation Research. I'll send the link out in the post-webinar email to you all, but if you have a pen handy, it's http://CDTR for Center for Diabetes Translation Research .WUSTL for Washington University in St. Louis .edu, cdtr.wustl.edu. But I'll send it out as well. I want to thank any of our partners from Washington University who were on the call. And I am going to send out a follow-on email after the initial one, just asking for any reflections on how we can continue to strengthen our webinars. But I agree, it was a great space, and we just wish you all the happiest of holidays. What a treat to be able to hear the Thanksgiving address today on this week. So safe travels to anybody who's on the road, and happy holidays. Good afternoon.